Starting now or still got 2 more minutes? Joining us for these sharing sessions. So actually, with the rising cases of COVID positive infected children, we are actually seeing more and more children also presented to us with MISC, which is also known as multi-system inflammatory syndrome. Sometimes they can be presented with quite ill in cardiogenic shocks. So today we actually are very fortunate to have Prof. Anis to agree to spend her time to share with us what is her experience on managing these cases. So Prof. Anis, she's actually a consultant pediatric intensivist from UiTM. She's also a head of department medical education. She's also a lead of our clinical simulation center in UiTM. So she obtained her undergraduate and postgraduate in pediatric in Universiti of Malaya, and subsequently further pursue his subspecialty training in pediatric intensive care in Birmingham Children's Hospital. So without further ado, I would like to invite Dr. Anis to present her talk. Thanks, Dr. Anis.
Okay, thank you so much for this opportunity to share my experience. I think you put up the topic as how to extinguish the burning fire. Well, that was actually quite a funny story when we discussed among ourselves, all the PICU members in Malaysia, that we are seeing a lot of MISC now, especially starting, I think maybe after March this year, that we are seeing a lot in Semenanjung. I think Sabah has seen it before us, and then I think Malacca also seen it last year. But in around the area of Klang Valley, I think the numbers were rising starting I think early this year. So when we were talking about that, and we were like, things can go so wrong in a MISC patient, and some of the patients can be quite mild in terms of their presentation, but some of them can be quite extreme in terms of the cardiogenic shock that they present with. So then we were talking about using steroids, and using steroids, you have different types and different dosage, and that's when I think it comes from the discussion how much steroids that we wanted to use, and that was when the talk about trying to extinguish fire from a bushfire using a garden sprinkler. So it is probably not appropriate if you have a bushfire that's ongoing with a lot of fire. Then you just go in there and then just try to sprinkle it. And this also comes from the rheumatology team in Selayang. So we had a good laugh, and then we actually discussed on which one is probably the best for the patients. So a little bit of disclosure. All the pictures and videos are with consent. I'm going to share some pictures and videos of our patients that with us. And a big credit to Hospital Selayang team. I think we couldn't do this without a very strong team in Selayang, and including Rheumato team under Dr. Tang, Dr. Sen Chin, and everybody in the team, and nephrology as well, Dr. Selva, who has been very helpful, and adult nephrology as well, has been very helpful in managing our patients that's very, very ill. And credit to hospital, that's hospital HSA, Shah Alam, and Sungai Buloh team as well for managing very ill patients and be able to identify these patients and call early for help. And also credit to UiTM team, whereby the hospital wasn't actually really open yet, but because a baby landed there with a very severe MISC, and the whole team had able to help the baby until discharge. And special thanks to Dr. Cho and Prof Khan for always being there, always pick up the call whenever I'm in distress and need some help. So the outline of representation now is we're going to talk about COVID now, what's happening to COVID-19, and can we anticipate what's going to happen in the next couple of months or next year. A little bit of immunopathogenesis. This is very new, something that a lot of papers has come up on this immunopathogenesis, and that is where the understanding of how we treat these patients come about. I'm going to talk a little bit on the clinical phases that we are seeing, and some case series, and we will end this session with a cardiac imaging talk by Dr. Amy. Dr. Amy has been kind enough to see all of our patients and co-manage our patients together. So this is data from yesterday that we are seeing now. This is probably the MCO, the previous MCO, and then after that we saw quite a large number of cases in mid-August. So as we know, when there's a lot of COVID case, from the data from internationally worldwide, we know that after a surge of COVID cases, we will see within around 4 to 6 weeks after a surge of COVID cases, we will see a rise in number of MISC cases. And that actually relate to the immunopathogenesis of the disease. So we can actually anticipate what's going to happen soon. If you look at here, this is end of last year. We had one surge, and then we had this MCO 2.0, this MCO 3.0. And after that, we were seeing quite a number of MISC, and I just wanted to bring your attention here that even the fully vaccinated or partially vaccinated cases are also people that vaccinated is also rising, but I'm guessing that the clinical condition is not that bad. Okay, you look at the cases by age group, and you will see that the number of cases in children are also rising somewhere in August, September. So August, September, if the numbers are rising, then you can anticipate MISC is probably going to come within this October, November. These are the numbers by age group, the percentage by age group, and we can see that for children less than 11 years old, the numbers are quite static, and we have to be more vigilant in terms of the patients that we are seeing that come with MISC. Most of them are healthy children. And then we can see that the numbers here are not reducing in trend. It means that if they have COVID infection, they may have MISC somewhere around 4 to 6 weeks after the first presentation, some as early as 2 weeks. This is a number, total number of COVID-19 admission, credit to Dr. Cho, and this for the whole country. So we can see that the number of COVID-19 admissions actually went up in children in May. Then it went up the highest in August, and then now is coming down trend. But the number is still quite high. And I'm not too sure whether this is actually underrepresented or not, whether we did the testing or not for these kids, and that is probably the reason why we are not seeing the number high enough. So if you look at the rise of the number in total in the whole country, so it actually increased together with the number of pediatric patients with COVID-19 admissions, and these are I just wanted to inform everyone about the MCO, and then the last MCO was 28 June, and we were seeing quite high number after MCO was lifted. And now that the children are going back to school and things are going back to normalization, so we can anticipate that the numbers of MISC might rise in the next couple of months. Okay, so you look at this number, the orange is Cat 5 that we are seeing in the hospital, and the blue bar is Cat 4, and the grey bar is actually MISC. And you can see that the numbers of Cat 5 is not so many anymore, but we are seeing more of MISC. If you look at the number of deaths per month, in September alone, there were like 16 deaths out of 54 cases of MISC. So I think that is quite a lot and quite alarming. So, having said this, how do we actually identify patients or children with MISC? Looking at their phenotypes, how they present. So this is actually the paper from Slapback. I actually adapted a little bit from there. So when we look at how do we actually identify MISC, they usually come with 3 types of presentation. The most easy to identify are the ones that comes with Kawasaki's presentation. That is actually quite clear cut. You can see it. You can see all the cutaneous manifestation, and then it's usually they are a little bit older than the usual Kawasaki disease group, and then most of the time you will get COVID antibody positive and a very high CRP, and then treatments are almost about the same as Kawasaki. But there are another two groups that likely to come to you with a viral-like illnesses. And sometimes people mistaken as dengue, and sometimes people mistaken as streptococcal or staphylococcal infection. And usually ASOT will be high in this patient anyway, because it's an immune related disease. So when they present with the most severe ones, will present with a shock-like presentation at presentation encounter with the healthcare professional. And most of the time they will present with two types of shock. One is a cardiogenic shock and the other one is septic shock. So when you see this kind of patients, most of the time you will see them to have a very low blood pressure. Sometimes they come with a lot of arrhythmias as well. And then they are warm. So they are not really cold, peripheries and the pulse volume, but they are really quite warm. So because they have this endothelial dysfunction that comes together with this cardiogenic shock. So some people actually mistaken with dengue because sometimes because of the endothelial dysfunction, they have a little bit of pleural effusion and ascites. Okay, then you have this undefined inflammatory presentation, which is just fever, like viral illnesses. And these are the ones who usually presents quite mild. And sometimes you don't even need to treat, but sometimes they do need a little bit of steroids or IVIG. The ones that I'm actually, that we are seeing now in PICU are the refractory MISC. So this refractory MISC, usually there's a lot of guidelines now. There's a WHO guideline, there's a CDC guideline, there's a guideline from Europe, guideline from America. But I think one of the guidelines, which is from Switzerland, they actually mentioned about refractory MISC, which is whatever that we are seeing currently. The refractory MISC are usually the ones that have persistent hypotension, has a lot of arrhythmias despite you giving the IVIG and metapred, and the condition usually worsen within 24 to 36 hours after the presentation and did not really respond to the first line treatment. Okay, what is MISC? So MISC is actually, this reported last year. There were peak of incidents during the peak of COVID-19 pandemic in the US and in the UK and actually worldwide. So the patients at that point of time came with a Kawasaki disease-like with cardiac dysfunction, elevated ferritin, CRP, and often presents about 2 to 4 weeks after first exposure. So these patients came very, very ill, some requiring ECMO, and there are a lot of biologics has been tried out, but most of the time the treatment will be IVIG and steroids. So this is actually the case definition. So if you look at WHO case definition, anybody with fever for 3 days, with rash, hypotension and shock, myocardial dysfunction, evidence of coagulopathy and elevated D-dimers, acute gastrointestinal problems. So sometimes they can come with abdominal pain, and sometimes we mistaken it as acute abdomen, and they landed under surgical department. And sometimes they can have, most of the time they will have elevated ESR and CRP, but when you actually take the blood at the first time during admission, if the CRP is low, please repeat it again, because this is a very dynamic kind of disease, and sometimes when you do once doesn't mean that the inflammation is not there. And most of the time when the first CRP is actually quite low, you repeat it the next day, it will rise. And there were no other microbial cause of any inflammation or infection. And evidence of COVID-19 RT-PCR or serology positive, which is either COVID antibody towards anti-nucleocapsid or towards anti-spike protein. and likely contact with patients with COVID-19. So sometimes it's difficult. It's difficult to get this at diagnosis, at admission. But high index of suspicion when you have all this, when things doesn't really jive together, when the patient had fever but the CRP is like way high, like 150, 200, or when the patient comes in with cardiogenic shock, but like I said just now, but it's quite warm, so it doesn't really, you know, like that kind of a sympathetic activity that you expect in a heart patients where they get very cool and clammy. And sometimes to get the history of contact with patients with COVID-19 is also quite difficult, because before the school starts, they were all at home. And when they're at home, only the parents actually go in and out. And sometimes we do not test, and the parents are most of them are vaccinated. Therefore, they are asymptomatic. So you're not sure whether you have you are a carrier of the virus, that you can actually pass it down to the kids at home. Okay, so this is actually at the current moment the criteria for MISC. And now we also have MISC A for adults. Okay, this is just epidemiology of the cases that happened. And this is part of the pathogenesis. These children develop hyperinflammatory response. Why? There's a lot of things. The trigger might be because of the SARS-CoV-2 virus, but the inflammation comes about a bit later, mainly because of probably the innate immune system. And this will actually induces a lot of cytokines, interleukins, and then a lot of toll-like receptor triggering at the cell level, and that is actually causing a lot of inflammation going on. And the most areas that abundant with ACE2 receptor, which where the SARS-CoV-2 are the glial cells in the brain, in the heart, as well as in the gut. So that's why children in MISC, usually they will come with all these three kind of organs involvement, which is the heart, the brain, and the gut. So how do we know whether this is actually a severe COVID infection or is a MISC? So a MISC is actually a post-infectious, so it's no longer infectious. It means that you can put them in the general ward. I mean, it's not necessary you put them isolated in the COVID ward. They are non-infectious. They are already seroconverted, but because they are associated with hyperinflammatory response. So most of the time, the MISC patients, they usually will, rarely they will come with respiratory symptoms. They do, but in a very low percentage. They will usually come with heart, a little bit of maybe vomiting, diarrhea, and sometimes they can come with encephalopathy. So those are the ones I usually miss. But the ones that severe COVID, the severe COVID ones, usually they will get some respiratory symptoms, and with this they will have fever, and they will usually deteriorate around day 6, day 7, day 8, and day 9, going towards severe pneumonia and going towards ARDS, that is Cat 4 and Cat 5. But in MISC, most of the time they will have fever. They will have all these symptoms that most of the time is not respiratory, and they will come with a shock at around day 4 and day 5. So almost like dengue type, but that's why it's, you have to have a high suspicion of index when you see a patient actually presented to you with shock during this time. So this is all the manifestation of MISC. Okay, a little bit on immunopathology of MISC. So most of the time, they will have cardiovascular involvement. Some of them will have KD-like features like skin rash, all those, swollen toes and finger pups, and red lips and all. But the problem is that what happened is that there will be an innate immune response with fever, with high CRP, ferritin, and D-dimer. And this actually induces, all these macrophages induces interleukins 1 beta, interleukin 6, and also tumor necrosis alpha. And these are the ones that are causing tissue damage, and it's sort of like autoantibodies that's attacking mainly the heart, lymphoid tissues in the abdomen. That's why sometimes they can come with almost like appendicitis, like picture, and they can also come with neurological signs. Okay, so our case series, like I mentioned just now, this is just observation. I'm just sharing the cases. I'm not an expert in MISC, but these are all that we are seeing. We have a total number of, I think, around 25. And then usually they will present around day 4 to day 6 with cardiogenic shock. And from our observation, when we do echo, we will see some area of fat attenuation, which is some brightness around the area of coronaries, although the coronaries are not dilated, but the brightness is there, and then I do not see it usually in other conditions. Some of them had splenomegaly, so they usually stay at home, so not necessarily they have positive contacts, history of unwell, but you just need to have a high index of suspicion. So this is what I mentioned about just now. This is the area of the left coronary, and you can see this brightness, which is a fat attenuation at the level of the coronary. And we can see here there's a thrombus in a LAD as well. So maybe perhaps this fat attenuation could be one of the prognostic factor. I'm not too sure. Maybe this is probably one of the thing that we should look out for when we are not sure, is this MISC or is this any other disease? Maybe just do an echo and then have a look what's going on near the area of coronaries. So the story of a MISC, so what's going to happen is that they have fever for about four days, and then they develop this cardiogenic shock and septicemic shock. Then the next day, or usually after that, we will follow it with BQ mismatch. This is because they have tendency for thrombosis, and we have done a CTPAs in our patient, and we saw microthrombitis in the pulmonary capillaries when they actually present with increased respiratory distress. So if you look at the X-rays, the X-rays usually not too bad, not fantastically, ARDS type or increase opacities, but mainly it's actually kind of oligemic with a very minimal opacity. So these are all VQ mismatches, and they can be quite increased work of breathing, and some required intubation. The other thing that is common is neurological abnormalities. So some of them presented with seizures, mainly because I think one of it because they have very high fever. And some of them come with encephalopathy, changes in behavior about a few days before they actually present to you with cardiogenic shock. And that's why usually in ICU, we do transcranial Doppler to ensure that the blood flow to the brain, because they are already having hypotension, shock. So we have to ensure that the flow to the brain is good so that we maintain the brain perfusion. And we did MRI brains because we wanted to learn more about these patients. So when they presented like that, we did MRI brains, and most of the time it's actually normal. Even EEGs are normal. But we do have one patient who had peripheral neuropathy with hyperesthesia after they recover from MISC, but we thought that it could be probably because of one of the reasons, because critical illness polyneuropathy. So we're not too sure yet. Gastrointestinal abnormalities, commonly they present with diarrhea and vomiting. Infants, okay, so we had 2 infants, not really infants, almost neonate, 1 month old and 2 months old. So instead of they present with diarrhea, most of the time the bigger children, after they came in with shock and then they had this VQ mismatch, so they go on respiratory support. And then after that, they will have some GI problems. Either they are not tolerating feeds or they have diarrhea. So most of the time they will have like profuse diarrhea for a couple of days before they actually get better. The infants, they do not develop diarrhea. Instead, they develop abdominal distension. So very gassy, and then we had to like start TPN and off the feeding, and then just to wait until everything settles. So probably one of the pathogenesis is related to the lymphoid tissues in the gastrointestinal. So the treatment is IVIG, about 2 grams per kilogram in total. Steroids, either dexamethasone or metaprednisolone, and we usually pulse them if they present with shock. Biologics that we can use is anakinra, tocilizumab, infliximab, or convalescent plasma. I'm actually a bit, I'm not too sure about convalescent plasma, because then you are actually giving antibodies to the patient. When you're giving antibodies to the patient, I'm not too sure whether that will heighten the inflammatory response even more in the patients with MISC. Aspirin if they have coronary abnormalities, and subcute enoxaparin, Klexane. Usually we use Klexane for the ones with high D-dimer and thrombotic. Inotropic support, like we mentioned just now, usually they will have a bit of cardiogenic shock, so requiring low-dose adrenaline and Mirinon, and a little bit of septic shock because they're very warm. So then sometimes I added a bit of noradrenaline. So this is just a snapshot of our outcome. We have a collection of data from patients in-house, either from ED or referral from other hospitals, or co-managed with a respective team in other hospital. So total patient, we have around 25. Age range is from 1 month old to 12 years and 1 month. Weight range is around 3 kilograms to 66 kilograms. We had all of them survive. Complications, the one that I mentioned just now, she had foot drop. And most of them discharged with good EF, 4 required CVHDF, 3 required plasmapheresis, and 1 required anakinra. So age in month, so most of them around, I think, toddler age group. This is the age range. The race is just reflecting where our patients coming from. Weight, in median weight is around 25 kilograms, but the smallest that we had was 3 kilograms. And during treatment, it dropped even further to 2.4 kilograms. Hospital length of stay is around 13 days. PICU length of stay is 5.5 days. Invasive, half of them actually had to be intubated. Length of ventilation is about 5 days, and the survival just now is about 100%. Okay, so we see this is the length of stay. So we can see that some of them actually stayed quite long, around 1.5 months. And the age group commonly is around in a toddler age group. So days to presentation. So as what we have seen clinically, we are seeing them around day 4 usually, but most of them also come with at day 6. And usually some present very early, about 35% of them present very early to ED, less than 2 days of symptoms before they present to us. The symptoms, 90% of them had fever, 60% had Kawasaki's kind of disease, 30% has URTI, 50% actually comes with shortness of breath, abdominal pain, 15%, vomiting and diarrhea, more of a vomiting, but it's almost the same, about 50 and 40%. They are quite sick, so that's why they come with poor feeding, so about 70% of them. And neurological symptoms with seizures and encephalopathy, around 15 to 10% of them. And also they can come with UTI symptoms, about 5%. I'm guessing that when they come to us, because all these are quite non-specific symptoms, abdominal pain, vomiting and diarrhea and poor feeding, but we do not routinely actually check for urine. I think probably this patient actually came with truly UTI symptoms, and that's when the urine FME was actually showing UTI, but in the end the patient actually had MISC. So most of them actually presented with tachycardia, about 75% of them. Almost half of them actually presented with shock. And you can see here, respiratory symptoms is actually not the main symptom in MISC. And only 15% of them come with episode of hypoxemia absentation. If you look at the white cell, it's normal here, but many actually come with a low white cell. So that's why it looks like kind of like dengue kind of picture. And with the low platelet, the lowest would be was 56. The urea and creatinine usually is normal, not so much of liver dysfunction, but if I can draw your attention to the albumin is also quite low, about 24. This is probably signifying the endothelial dysfunction, where you probably leak albumin to the third space, and some of them actually develop perfusion and ascites. The PTT is slightly prolonged, but INR is usually normal. The CRP can go as high as 200. Most of them had about more than 100, but the mean is actually 52. PCT is around 36. Ferritin not too fantastically high, is about only 1,000, and most of the time we are seeing around 300 to 500. Troponin I and troponin T is around 2,200. We had one, I think the highest we had was around 13,000 troponin. And anti-pro-BNP, so we did pro-BNP because sometimes when we actually seeing our patients, when they are already under treatment, CRP, PCT, ferritin, trop I or trop T doesn't really correlate well with the clinical progression of the illness, especially when you talk about cardiogenic in nature. So we actually proceeded in going more into doing pro-BNP, and one of our patients had a pro-BNP of 56,000, and that is actually our youngest patient, is the 3-kilogram baby. The pro-BNP was 56,000. So the mean is actually 30,000, so it's very high, and then it's quite correlated with the clinical illness as compared to troponin, CRP, PCT, ferritin, and the rest. D-dimer, usually they have high D-dimer because they are quite thrombotic, and then fibrinogen usually is not that high. We also did interleukin cytokine profiles. We sent interleukin 1, interleukin 6, interleukin 8. And we can see that some of them had high interleukin 6, and but not so much of interleukin 1. If you look at the immunopathogenesis just now, the interleukin 1s are the one that usually actually attacking the heart, and that is why we actually, in one of our patients, we chose anakinra as anti-interleukin 1 to treat the heart condition when all other things are actually not. The patient did not respond to. And tumor necrosis alpha is about 20. So this is a CRP. So you can see the trend can go up very, very high. This is the ferritin. So ECG, most of them had sinus rhythm, some had sinus arrhythmia. We had 3 patients with long QT, and we had ST elevations and T inversions as well. So it's quite scary to see ST elevations in children. And then at one point we were like, oh, are we dealing with MI or things like that? Echocardiogram, if you look here, around on admission, EF less than 30%, about 25% of the patient. EF 31 to 49, about 20%. And more than half, slightly more than half, is about 55%. But at discharge, you can see the patient actually got better. The EF less than 30% is about 5%. and 31 to 49, 10%, and most of them actually regain back their heart function. And we did cardiac MRI post MISC in 3 of our bigger patients, and all showing normal ST elevations and T inversions, and she was diagnosed to have myopericarditis as well. So this is actually what the inflammation that we see in the cardiac MRI, the pericarditis lighten up. So require inotropic support, about 60%. We started on Clexane. Anti-heart failure, about 25%. So even with a very debilitating cardiogenic shock and very severe heart failure, but in the end, only about a quarter of them actually goes back with heart failure medications. Anti-arrhythmic, about 25%. This is what we use. So initially we were using Metapred 2 mg per kilo. I was using Dexa or Hydrocort given the initial cases, but I find that when you're desperate because of the heart was really, going downtrend in front of your eyes, then you just need to someone with very severe heart failure and then heart compromise. So that's when we decided to go on a 30 milligram per kilogram, and together with the Rheumato team in Selayang. Okay, so all of them, or only one of them didn't actually receive any treatment. One of them actually just recovered without any treatment. So that's probably the one yang just persistent fever, but nothing much happened to the patient. We actually started Anakira in 2 of our patients, and we have about half of our patients on mechanical ventilation with median days of 8 days. CRRT, when IVIG and Metapred didn't work, so we continued to that is when I actually talk about the refractory MISC. So we gave 24 to 36 hours for the Metapred and IVIG to work. If they do not work, then that's when we go on CRRT and also plasmapheresis. Okay, so this is a case illustration. I'm going to show you pictures and videos of our patients, but these are all with consent from the family members. So case 1 is a 4-year-old boy, 18 kilogram, had history of fever. The way how he actually presented to surgical department first. A CT brain, and then it was turned out to be normal, but because of the fever and all, the pediatrician did CRP and then noted that CRP was high, 135, and subsequently he actually went into hypotensive shock with a 2-to-1 heart block, and his strop I was 13,000. So when we started IVIG 2 gram per kilogram and Metapred 30 milligram per kilogram. At that point of time, his after completion of IVIG and Metapred, which is around 36 hours, his BP just continuously dropping, and his heart rate was continuously dropping down to 50 and 60, and his ejection fraction actually initially was about 30%. It went down to 10%. So that was when we actually electively intubate the patient. Patient was still actually looking around and all. That's the thing about children. Sometimes you don't see them really in the decompensated phase until everything actually just going to collapse on you. So we intubated the patient, and then we started CVHTF. This is actually the one that I mentioned just now. We see in all our patients this bright thing around the area of coronaries, although the coronaries are not dilated. This is him. So we did a CVHDF mainly because we needed to remove fast the cytokines, the interleukins, all the things that are actually irritating the myocardium, and that has been causing the ejection fraction actually to drop even further, and the patient went into heart blocks. So his COVID investigation all negative. So we were like, is this MISC or is this, what is this? Is this just viral myocarditis? What is this? So, but we were actually treating him as per MISC. So the first antibody that we sent, the nucleocapsid protein and spike protein, were non-reactive, but I did not actually check again after that. So only when about 5 weeks later, then I asked them to, why don't we check again the COVID antibody, and it turns out to be positive. So sometimes you need to repeat the investigation to make sure that you're getting the disease right. So this was him just before he goes back home. Then this was him first day at home with his sister. Case number 2 is an 11-year-old girl who came with a chest pain for 2 days. So it's quite a sad story because she went to KK, she went to clinic, and she even went to hospital 4 times before she landed to us with a chest pain. Because it's central in nature, and then they were treating her as gastritis. Then history of fever, not so much, but she does complain that some low-grade fever, but it wasn't her main concern. Her main concern is chest pain, and when we asked, it's actually a chest pain during inspiration and is centrally located. So then we did ECG, and we saw these ST elevations at around all the chest slits, and then some T inversions as well. This is actually quite a big girl, like an adult size. And her CRP was 56. Her BP and heart rate was actually normal at that point of time. So because of this, we suspect MISC. No past history of contact with anyone, but anyway, we actually took all the bloods and then it looked like MISC. So we gave IVIG and Metapred. So her BP was always okay, but her heart rate is, not that nice for 11-year-old girl, around 120 to 130. Ejection fraction is actually 50%, which is okay for children. But the thing that puts me off is actually the color of the child. So her lips was pale. If you look here, her lips was actually pale and a bit cyanosed, although her saturation was 100%. So when you see this in a patient with a quite not correlated lip color or the color of the patient with the saturation and the blood pressure and all. So you know that there are probably 2 things. One is actually severe metabolic acidosis. The other one is sympathetic overdrive because of cardiac heart failure. So because of that, I figured that, okay, probably just intubate her to just make sure that the heart actually doesn't struggle. Then true enough, 2 hours post-intubation, her BP dropped and her ejection fraction just quite dramatically dropped down to 30%. She had a lot of arrhythmias. I don't know what to say about her arrhythmias. She throws everything under the sun. She had 2nd-degree heart block. She had intermittent VF. She had ST elevations in everywhere. She had T inversions. So we started her on IV adrenaline and no adrenaline. Then I did a CRRT for her. We did CVH. But one thing in MISC, the filter clots very easily. So because usually I will actually take care of the filter so that it actually lasts for its half-life about 3 days. But in MISC patient, it clots very, very easily. Within 4 hours, it clots, and then after that 6 hours, and then 8 hours, and then 12, and then 24 hours, and then we were changing the filter every day. The arrhythmia was better. There were no more ST elevation, but there was some on and off, heart blocks and then T inversions. So with that, we were thinking that could it be there's persistent irritation still at the level of the myocardium. So we are not talking about cytokines or interleukins, or maybe I was thinking about, removing more of these cytokines. That's when from the 5th filter, I attached together with the HA330 Jeffron so that there is more cytoabsorbent to remove all the cytokines. But after that, it got better a bit, but she was actually throwing off heart blocks and intermittently down to 30 beats per minute together with hypotension and hypertension. So don't know what's going on with the heart. So I figured that this must be something more than that, probably we just remove all the, plasma and then give a new plasma. So that's when we started on plasmapheresis, and you can see here the heart rate is much better, the BP is much better, and then we did double volume plasmapheresis once, and subsequently her ECG was totally normal. There were no more ST elevations, no more heart block, and no more T inversions. It's totally normal. This was her before we discharged her. I mean, her voice is a bit coarse because of post-intubation.
Good job, Noreen. Yes.
Okay, this is another case which were treated as dengue. So he had fever for 4 days, shock and encephalopathic, and he had pleural effusion. So was given fluid as per dengue. I mean, it's not something that probably not people that won't do, because you see the low white cell, low platelet, there's pleural effusion. So he was given quite a lot of fluids, and subsequently, after giving fluids, the condition actually deteriorated. His systolic BP actually dropped down to 60 to 80 millimeter mercury. Overnight, he had positive balance of 3 liters and had poor urine output. I think he had some AKI already sets in. So he intubated and then started CVHDF, gave IVIG and metaprep. His EF was 30% and it dropped down to 10%. That's when we actually continued the CVH. We continued up to about 6 days until the EF actually normalized above 40 to 50%, and the ECG actually was showing normal findings. So his PCT was very high. It was 438. I've never seen that kind of PCT before, and the D-dimer was also very high. So he's on Clexane. So this was him upon discharge.
Okay. Thank you, Peter.
Okay, so this is another case. One of our youngest and one of our smallest, not the smallest yet, 4.5 kilogram, 2 months old, presented with 1 day history of unwell and collapse. He had persistent SVTs, VTs. I also tak tahu dah, because his heart rate was up to about 300. ECG later, when we did ECG later, it was actually showing long QT. He had IVIG 2 grams per kilogram, metaprep for 5 days. I actually started CVHDF on day 1. During the stay with us, he had cardioversion ×2 because of the VT and VF and whatever arrhythmias that the patient was having. He had CPR of 12 minutes. And it's similar like the previous case just now. I was thinking that, this persistent arrhythmias and persistent poor EF, probably we have done something by removing the cytokines fast using the CVHDF when the patient actually did not quite respond to IVIG and metaprep. So we plan to do exchange transfusion, which we did twice, but nothing happened after exchange transfusion. He still have quite a lot of arrhythmias here and there. And so at that point of time, because of his weight was very small, about 4.5 kilogram, we couldn't find a proper filter for plasmapheresis for this very, very small baby. So when we discussed with the nephrologist, discussed with vendor, we managed to get filters from Japan that flown over within 3 days for us to do plasma exchange for this patient. And so we did twice plasma exchange double volume, and subsequently that's when we saw the long QT in the ECG, and that's when we actually started with bisoprolol and then optimized the magnesium and calcium and whatnot. Okay, so this was the patient's heart rate at presentation. and it was basically the heart on admission. And this is the baby when we actually did the plasmapheresis. And if I can show you, this was the baby just before he goes back home.
Dah sihat dah, nak balik dah.
Okay, the last case that I wanted to share with everyone is a 1 month old. We just had recently, still currently with us, a 3 kilogram baby, fever for 3 days, came with collapse state. His EF was 25%. His ECG, her ECG, initial ECG was already showing long QT 0.58. And she was referred to us because of persistent hypotension with a systolic BP of about 40 millimeter mercury. So we gave IVIG and mitopret, and these are the refractory MISC. So even after IVIG and mitopret, we give some time for the patient to see whether the patient actually responded to the immunomodulators, but her EF was just dropping and it was just like, merely contracting. So at that point of time, we were thinking how to do this. We do have some of the filter left from the previous patient that is suitable for this patient. So with the high risk consent, we just asked the mother, shall we do plasmapheresis for this baby? I did not opt for exchange transfusion because we actually did that from our previous patient and it did not really work. So we did plasmapheresis for this baby. So we managed to do 1.5 plasma volume. And this is the one with a very, very high pro-BNP. So we gave IVIG over 2 days, total 2 grams per kilogram. Because of the line itself is actually quite big. The GAMCATH itself for the CRT and plasmapheresis is very big for this patient that even the tip I had to put at the area of the IVC. So because they are thrombotic, I'm worried about having lines. So I actually removed the line after the first plasmapheresis. And subsequently, the initial ECG was showing ST elevations and T inversions in this patient. After plasmapheresis, we could see resolution of the ECG. The T inversion is sort of normalized, and there's no more ST elevation and no more long QT. So, but after about 2 days, because I think maybe we just did once plasmapheresis, there were like ST depression. It just starts to come back with T inversions. So then we started Anankira. We discussed together, Dr. Tang and the Rumato team. They have some Anankira that we can use for this baby. So we used Anankira for 7 days actually. And we could see after the Anankira, there is some resolution a bit of the ST elevation and T inversion. And definitely there were no more arrhythmias, no more QTs, but there was some at the anterior chest slits, some areas of ischemia. But it's better from before. And then the EF that we did from Simpson method, it was 10% before the plasmapheresis. After the plasmapheresis, the EF went up to about maybe 40%. But when we use the M mode, it's nearly 50 to 60%. There are some parts of the left ventricle that is actually not really moving. Nanti Dr. Amy will actually show that to all of you. So we started this patient on bisoprolol as well. Okay, so I think that will be my part. So perhaps I can stop sharing and Okay, Amy, would you like to take over? Is Dr. Amy from HTA? She's the consultant cardiologist that we actually send our cases to.
Thank you very much, Dr. Anis. It's a very great honor to be involved with the team from Selayang. They did a very wonderful job on all these patients. We actually saw 14 of their patients. So I'm just going to highlight here that the date we review the patient means is about 15 days, meaning that most of the patients are already almost recovered. So the earliest we saw is after 6 days of diagnosis, and mainly and there are also up to 1 month post-diagnosis. So most of them are actually almost recovered. So basically what we saw in most of the patients, the coronary artery are normal, except in one patient who had a coronary aneurysm over the secular aneurysm over the left main coronary artery. But mainly most of them, the coronary are already normal, probably because they're already being treated. And only 4 of them has perivascular enhancement, like what Dr. Anis showed before. And when we saw this patient, 3 patients still have LV dilatation, 5 patients still have pericardial enhancement, and 5 patients still has pericardial effusion. But the pericardial effusion is actually very minimal, it's less than 5 mm. And the systolic function was using mode and also Simpson, most of them has good ejection fraction because, as I've mentioned to you, they have already recovered. The Selayang team has done all the hard work. But we also see diastolic dysfunction still present in 4 of them, indicating that the myocardial is still recovering in this patient. So what we do when we are assessing diastolic dysfunction, we are using mitral EA ratio, we are using septal E prime and lateral E prime using the tissue Doppler imaging, which can also be present in your machine, which you can also assess in acute patient. We also look at the Goldberg strain for this patient. We only use, unfortunately, longitudinal Goldberg strain. It's done in 12 patients. We did not do in the earlier 2 patients which were referred to us. The normal is we want about -20. In most of the patient, we got average about -14. We have 4 with low global strain, 2 with very, very low global strain of -6. The lower the minus number, the poor the myocardial function is, indicating myocardial injury. So we also look at, this is not statistically tested, but also look that the global strain is actually lower in patients who had more invasive ventilation or required more ventilation support. We also noticed that the global strain is also lower in patients who has higher number of inotropic supports. As for the diastolic dysfunction, again, similarly, we also see a positive diastolic dysfunction in patients who are more ill because they require evidence that more required support, and also a similar patient who has more inotropic requirement. They still have diastolic dysfunction when we saw them, mind you, at around 15 days of admission when they're almost recovered and can come to us in clinic review. So I'm going to show you the echocardiography of MISC that can be a good way to monitor on your echocardiography. I'm sharing you an echo of one patient. Okay, this is a baby which was referred to us for a survivor successfully recovered from MISC. As you can see, even though the baby can come to us as a clinic visit, this baby still have LV dilatation, and also there's evidence of pericardial enhancement as well. On this echocardiography, this baby also has mitral regurgitation. Of all 14 patients that we saw, only about 3 patients has mitral regurgitation. The rest has no mitral regurgitation. And when we look at this, we also need to do TAPC and MISC. This is actually, TAPC is tricuspid annular systemic planimetric systolic excursion. Is actually to measure the longitudinal function of your RV. So this is normal. And this is MISC. We put M mode on the hinge of the mitral valve on the lateral wall. So this is also to measure the longitudinal function of the LV. So this is about 0.8. In a small baby, it's acceptable, but in a bigger child, you want at least more than 1. And in this patient, we also noticed that the diastolic dysfunction is still impaired. This is a very tachycardic child, so this is how we measure EA ratio, but it's a bit difficult because of the child is tachycardic. The EA ratio for this child is about 2, and we also do the studies on the E-septum. What we do is we put a TVI and put a PW on the septum as well as on the lateral part. Each septum in this child is 7. We want at least about ranging about 8, and E to E prime septum is about 20. So more than 15 means it's not good. And the lateral part for this child, the lateral, she managed to get E prime lateral of 10, but the EE ratio is still about 14.9, almost 50. So E prime lateral 10 is actually a cutoff of normal, but the E to E prime ratio is still not normal. And then if you see, if we plus together with the septal result that we got just now, this child still have diastolic dysfunction. We also look at the coronaries. So if you look at this, I just want to show you that this child has normal coronaries. And if you look at this child does not have any perivascular enhancement or enhancement of the fatty tissue, which Dr. Ani showed previously. And we also need to see also the short axis view, especially the myocardial short axis view in child with MISC, because the regional wall may be affected. So in a patient with MISC, we must remember that the LV itself can be divided into 3 components, of which is the base where the mitral valve is, and then the mid where the papillary muscle is, and the apex. So if you look at this echo, you can see the pericardial is still enhanced. We have pericardial enhancement, but we don't have pericardial effusion. And the M mode nicely showed that we got EF of 60%. But mind you, the M mode is actually at the base near the mitral valve area. So when we do Simpson for this patient, apparently the Simpson is still poor. The Simpson is about 30%, meaning that the mid and the apical is not still at the best what we want. And true enough, when we do the strain study for this patient, the strain is actually very, very poor. If you can see here, we want all this to be red. We want red eyes, and we want the number to be minus 19, minus 20, of which we don't have in this patient. And the overall global longitudinal strain for this patient is minus 6.9%, which is very poor. So this patient, we optimize the treatment of which Dr. Anis has given, and we also give the patient captopril as well. I think that's all for my presentation on the echocardiography component for the MISC. Thank you.
Thank you, Dr. Amy, for always I'll always answer my call, even at odd times. So, okay, I think I am going to share the last slide. As a summary, it's very, very important to have high index of suspicion. I think at the moment, because you see just now the numbers are still high, and then the movement of people, and then we are not really testing everyone anymore. So this MISC can come with any presentation, but as I said just now, usually high fever and then something that is a bit odd. Is KD-like, it's not a problem, but the non-KD-likes are the ones that you need to probably ask further history. About 4 weeks ago, anybody in the family had positive COVID, or about within 2 to 6 weeks of the presentation. So hopefully, probably in your clerking, you should include history of COVID positive or contact with any COVID positive patient within 2 to 6 weeks prior to the presentation of the patient, just to make sure that you're not missing things. We still have a lot to learn about COVID-19 and how it's affecting children. So all these children, we need to follow up and see how what's going to happen to them. Like the bigger children in our case series, we send for cardiac MRI, and then we are seeing the resolution of the heart function, although they had a little bit of diastolic dysfunction or had to be put on some medications. But towards after about 6 weeks, when we did the cardiac MRI, there's already resolution. There's not much of any inflammation anymore in the heart. MISC, most of them actually affecting healthy children. Seroconversion may occur 2 to 6 weeks post-illness. If negative, probably you just need to repeat. 2 antibodies that you probably wanted to check. One is antibody towards nucleocapsid, and the other one is antibody towards spike protein. Some of them, I didn't show here, but we actually analyzed how many percent actually positive towards nucleocapsid and how many percent positive towards spike protein. Actually, we thought that if a MISC, they are more, we're going to see a higher percentage of high positive in nucleocapsid, but actually we are seeing higher percentage of spike protein, anti-spike protein. That's why we need to send both nucleocapsid and spike protein. But now when the children are being vaccinated with Pfizer, so that's when you would see more of spike protein in the blood. Clinical presentation, usually viral or sepsis-like, and then they go into sudden cardiogenic shock. These are the ones that actually doesn't do well. So of the 3 categories, one is just undifferentiated fever, which is like usually they will be okay. The other one is a KD-like, which is easy for you to detect. And the other one is who comes in with a viral illness and then just collapse on you. So those are the ones that sometimes high index of suspicion, whether this is MISC, get further history, and please do all the investigation necessary like a CRP, D-dimer, LDH, fibrinogen, just to make sure that these numbers are not high. And even if the CRP is low on day 1, please repeat it on day 2, because sometimes we do see patients that comes in first day CRP is low, second day then it starts to rise up. 3 main organs that usually is affected: the heart mainly, the brain, as well as the gut. Okay, so they can come with acute abdomen. We've had a few patients that come with acute abdomen with a high index of suspicion of appendicitis, and once we start IVIG and all, everything actually just disappear, and it's actually just the patient actually didn't go for surgery. And then it was proven to be MISC. The perivascular fat attenuation, I was actually discussing with Dr. Amy many times. So why am I seeing this a lot in our patients? So perhaps doing an echo, try to have a look at the coronaries, maybe will help to differentiate whether is this MISC or not. Follow up these patients, cardiac complications, long COVID. So you would see that children coming in with lethargic, and sometimes they have palpitations, and sometimes they have, not really chest pain, mainly is lethargic, low mood, palpitations. So those are also one of the symptoms of long COVID in children. Okay, so I guess I will end my talk here. I pass back to you, Ms. Chairperson, Siwa.
Thank you, Prof. Anis and Dr. Emilia, for the excellent presentations. Is there any questions that you would like to ask Prof. Anis and Dr. Emilia? So, Prof. Anis, actually, I have one question to ask. Usually, in those patients are presented with MISC, is it common? As in, what is the selection criteria for you to perform a CRT on this patient? And then what is the what is the target? What's your goal to win?
It's so difficult because we don't know about this disease much. And then what we see in the overseas, they have ECMO and they have all these things. So what I'm trying to say is that the proportion of patients that go into refractory MISC, it means that you give them time within 24 to 36 hours to see whether they respond to IVIG or metapred. That's why I use high-dose metapred, because I actually need to see whether this patient, because they come with a very severe cardiogenic shock and hypotension with a lot of arrhythmias. So, and the EF will just within hours, we just drop from 50% down to 30%, down to 10%, just within a couple of hours. So that's why time is very important. And we immediately start IVIG and metapred. That's why I give high dose metapred, so that we would see the effect immediately if the patient will actually respond or will not respond to the immunomodulators. And if the patient persistently having a lot of arrhythmias, I also don't know what arrhythmia already. I've seen like so many arrhythmias, heart blocks here and there, and then down to 30 with hypotension. So it's so hard actually to see what is our marker. So I actually am guessing I'm just going clinical, looking at the ECGs to see whether there's any ST elevations, things that can irritate the myocardium. And like I said just now, TROP-I, TROP-T is good to do at the first time you do it, you will see high level, but it is not really sensitive for you to actually monitor the heart condition, because TROP-I and TROP-T, CRP, everything will actually drop very low, but the patient is still very symptomatic, and the ECGs are still showing a lot of arrhythmias with the BP are not controlled and all. So that's when I gave the most is 36 hours to the patient, and then I will start CRRT straight away, because then the immunomodulators are not working. I don't have anything else. The heart is actually failing. The child might die on me. So what I need to do is just remove whatever that's irritating the myocardium as fast as possible.
Anis, can I ask a question?
Yeah.
Yeah, thanks for the talk. Very, very good. I want to ask two things. The first thing is, while you're putting the patient on the CVVH, was their blood pressure very, very low? And if that case, did you just like, let's go for it since there's no way out, let's just do it and then type of thing? Or did you maximize all your inotropes as much as you can and then you put them on the filter? The second question I have is, when you cardiovert these patients who've got VT, VF and all that, did the cardioversion actually work or not? One of your patients, I think, had a cardioversion. Thanks.
Yeah. Cardioversion doesn't work. I think it's just the irritation to the myocardium. I mean, it's not something that you can just jumpstart and then things will go back to normal. So it's just persistently, like it's just not the immunopathogenesis. So it's just the interleukins, the cytokines, just attacking the IL-1, attacking the cardiac myocytes, causing more injuries. And this is actually why the heart is so irritable. And even with cardioversion, it doesn't actually work. Even with antiarrhythmias, I start a lot of antiarrhythmias, doesn't work as well. In fact, it's just gonna cause, your BP starts to drop, and also some are actually negative inotropic. Yeah? So before I start the CVH, of course, at that point of time, they have heart blocks, merely ejection fraction. Some of them I couldn't even actually measure what's the contractility. BP, I try to maximize as much as I can with inotropes, but as you know, we can't really use that much of inotropes because that's gonna just drop the BP even more, and you just have to choose adrenaline, a bit of NOAD and a bit of Mirinoma. Sometimes I just start a little bit, but I go up on the when I wanted to start, just go up on the catecholamines lah. So then most of the time when I start the CVH, the blood pressure tak adalah fantastic. It's not fantastic blood pressure. But if the patient actually responds, you will see within 1 or 2 hours, because when we actually remove it, you can see that the BP starts to increase, the heart rate starts to drop. Like that baby was 300, the heart rate. So once we run it about 1 or 2 hours, it just dropped down to 150, some 180, 150, slowly kind of dropping. So that's when we know that this patient is probably responding to the CVH and doesn't respond to immunomodulators or anti-arrhythmia or even cardioversion.
Thank you.
Yeah, my colleague Dr. Abidin actually would like to ask the questions.
Hi, Vi.
Is very good talk. Want to ask, how do you differentiate between a younger child with KD or with MIC presenting with KD-like symptoms?
Yeah, because nowadays, if they are older, it's usually MISC. But if they are younger, age macam toddler age group, so it's not easy to say that whether this is actually COVID related or not COVID related. One way that you might want to do is that you might want to do that D-dimer, because most of the time, KD doesn't really associated with thrombosis, but MIS, yes. The other one is COVID antibodies. Probably just, but the treatment is almost about the same. So still IVIG. It's either whether you want to start metapred or not.
But if you start enoxaparin, do you start aspirin as well?
Yeah.
For KD?
Yeah, I look at the D-dimers. If D-dimer is actually, the normal value in our lab is actually 0.5. So if the D-dimer is more than 0.5, I give the treatment dose. If the D-dimer is within 0.5 to 0.5 to 5 times normal, then I give the prophylactic dose.
So I need to start enoxaparin for all of them, is it?
The small ones tak start lah, tak berani. The 3 kilograms. How to start? Nanti bruises everywhere. So small. So I didn't start for the 4.5 and the 3 kilogram. But the rest, yeah.
Yeah, I got one question. What people have reported is MISC usually see 2 to 6 weeks after the COVID infection. So from the patient that you have seen, they fall into this period of time, or are they before or after?
Yeah, most of them I didn't show just now, but most of them, I think about 80% within 4 weeks. So it's quite typical history.
So the earliest and the latest?
The earlier, the longest that we have is about 2 months.
2 months.
Yeah, but I'm not too sure whether they had the first documented COVID was 2 months ago, and in between these 2 months they had another COVID infection. So we're not sure because it's all like usually we see it within 4 weeks, but if it's a longer time, the documented COVID infection, it might be the patient had COVID infection in between that is not diagnosed.
Okay. And one interesting thing that I also come across recently in the literature, they talk about patient if they have KD features, most of the time in echocardiogram, you won't see the coronary artery dilatation. So from your group, do you see this?
Yeah, most of our patients don't have dilatation, but they do have the inflammation around it. When they present, they will have this bulge of hyperechoic lesion around the area of LAD, which actually signifies inflammation, but not necessarily they will develop dilatation. So I think Amy showed just now, only one had a coronary aneurysm out of 14 that she saw.
So this coronary aneurysm one, is it a patient with KD features or without?
The one aneurysm, no, without. She's actually 12 years old. Yeah, she came with a very severe cardiogenic shock.
Okay,
Yeah.
Okay. I thought it interesting when I read about this. It says those without KD features, then you need to look at the coronary artery because they tends to have aneurysm. Yeah.
Anis, this patient that did not have the coronary the one that had coronary aneurysm, that one patient, during that cardiogenic shock phase, was there coronary dilatation at that time, or there wasn't, just the inflammation?
Dilatation was just all the attenuation of that inflammation around it.
So the dilatation happened later.
Yeah, it's probably happened across the time, but she was quite severe. But I think because her blood pressure and everything, she wasn't refractory to the immunomodulators. It was just probably ongoing. That's why some of our patients, we had prolonged steroids because of the inflammation is still there. But it's hard to actually monitor with the CRP and all, because those are really not, it's not like severe COVID infection. The COVID infections are really correlating with the CRP. But MISC doesn't correlate with CRP. CRP will be high initially, and then once you give the still be very symptomatic. That's why I think the BNP will be better.
Oh, the BNP is the marker you think is reliable?
Yeah, yeah, because I'm now using BNP to look at whether I need to do more or not for the patient. So because after the plaques, the little baby, the first plaques, before the first plaques, it was 56,000 BNP. For acute MI, an adult is about 500, the normal value. More than 500 is usually in an acute MI. So this baby had 56,000 of BNP. And then after plaques, it dropped to half, about 20 something thousand. And then that's when because we didn't do the second one because it's too risky to do. It's a very, very small baby. So that's when we started Anakira. And then after Anakira, it dropped to 5,000 and it dropped to 4,000.
How about fever? In terms of response to steroid and IVIG, which one respond better?
Fever, from my experience, steroids. Give IVIG at the background, but it's the steroids that actually drops the rashes. The rashes will start to. Okay, the rashes will sometimes just reappearing now. It just settles and then reappears, settles and then reappear. So that's when initially when we started with a low dose metapred and then middle dose metapred and then last time just bagilah whack 30 milligram per kilogram. That will just cause the rashes and the fever to disappear.
Yeah, I think we have only 6. We don't have so many like you, but also we find that the steroid is the one bring the fever down. Yeah.
And we have no infection, Prof. Gan.
Oh, no infection in your cohort
no
also?
infection at all, no healthcare infection at all. No BSIs, no VAPs.
Yeah. There's none
because
of them.
we use a lot of steroids, I mean, with the rheumato team.
But in the presentation, any one of them have a co-infection?
We actually check for everything. We check for all the virus. We check for enterovirus, the Coxsackie. We check for mycoplasma. I think only 1 or 2 had a co-infection with mycoplasma, but the rest, there's nothing come back from the viral panel.
So Anis, if you have more of these patients, do you have like a set algorithm now? What you're gonna do? Are you gonna give straight away high dose steroids, immunoglobulins, or is it case by case?
So maybe it becomes more clearer now that we have like 3 types. Like one is the KD one, that's not a problem, and then the other one is the shock that comes with shock, and the other one is just mild ones. So the one that comes with a shock, the KD ones can come with shock as well. So these are the ones that we will give IVIG and metapred if they come with shock and require inotrope. Metapred usually I give high dose kalau dia pakai inotrope.
So you go straight for 30 per kilo.
If they use inotrope lah. Kalau tak pakai inotrope, you just 2 mg. 10 mg tengok lah. Usually 2 mg lah kalau tak ada inotrope. But then you watch for about 24 to 36 hours to see which one are going to go into the refractory MISC. If they go into refractory MISC, those are the ones that there's high mortality that you need to intervene. Just remove it straight away.
And you will start with CVVH first, right? Rather than just plasma exchange straight away.
Yeah, that's another thing because 3 of all 4 our patients we started CVHDF. 3 of them had plasmapheresis. the last baby was having quite good urine output. So I was like, to start or not, because we don't have much of that HF20 filter. But I do have it, but I was thinking like, why not just straight flex the baby? But I feel that if you do CVH first, the patient's kind of stabilized. You know, you can stabilize everything. It's easy for you to control the fluid, easy for you to control the electrolytes and everything. And then you do plex. I think that would be better, because when we did plex on that little baby, we start plex straight away. I think semua orang pun sakit jantung lah masa tu. It's not just the baby yang ada arrhythmia. Orang belakang-belakang tu semua sakit jantung already. Because it's quite risky lah. I guess maybe next time I would probably do CVH dulu, stabilizekan, then plex.
And you're using the same catheter, right, for both plex and your CVVH? It's the same dialysis catheter?
Yeah, same.
Okay.
Anis, your patients, is it all of them come with shock? How many percent of them?
Half, 55%. 55% ke 60% just now, come with shock.
Okay, so you know there's an algorithm that the American College of Rheumatologists,
Yeah.
so
yeah.
it's like 100% will receive IVIG, then only those with shock we give steroid, and then if we have refractory, then the steroid dose will increase from the 2 per kilo, then go up to 10 to 30 per kilo. So would you modify it and share with the group?
I think when the patient comes with shock, definitely IVIG. And if you want to give metapred, you can give the low dose metapred, the 2 per kilo. But if they need inotrope, I think you probably just give 30 per kilo, because you're not too sure whether they're going to go into the refractory MISC. When they go into refractory MISC, you might not have much time left for you to do more things. So that's why once they require inotropes, then we just start 30 per kilo, because we can see that after that 30 milligram per kilogram, the recovery is very fast if they are not the refractory MISC. But if they are refractory MISC, we can see that after 4 hours, we can see already, oh, okay, now metapred doesn't work. Okay, next step. Because then you don't lag on the treatment time.
The refractory group, in addition to the higher dose steroid, don't you actually consider use the interleukin 6, the tocilizumab?
Tosi, most of our patients Tosi are normal.
Oh,
not normal. Interleukin 6 are normal.
6 is normal.
Are not that high. Yeah, that's why we didn't give Tosi.
Okay.
Anis, do you based on using biologics based on your IL-6, IL-8 and all those the levels? Do you all do the levels then decide which one to use, or?
Yeah, we do the level at the cytokine profile. The rheumato team is doing a good job with that. They're doing the level and then send it to IMAR. But most of the time, interleukin 6 is actually in-house. We have in-house lab doing that, so that we can get quite fast. So that's how we know that probably Tosi won't help.
What about those in shock? You're giving 30 milligram per kilogram already of metapred, right? And then after that, you think that they need inotropes. Will you straight away give them some biologics?
That's why if they are into the refractory MISC, you give biologics, it's probably going to take some time.
Okay.
Right? It's just probably us racing against time lah. Then that's why the little baby too, after the first plex, I just start Anakira. But the first thing that we did was just remove it first, and then because I'm not too sure if we give Anakira. Usually we can see the effect within 2 or 3 days. But whether that time is okay or not.
Yeah.
Sorry, Anis, just want to check with you. I might have missed it, but all your MISC patients, are they PCR positive still, or you all didn't check? Or are they PCR negative already?
Check, I tak je. I think around 60 to 70% are still PCR positive, but it's actually very high, like a CT value of above 30. We do have one or two yang ada macam near 20 lah, dia punya CT value. Tapi most of them are like above 30. So it's probably viral shedding lah rather than infectious.
Sure. All right. Thanks.
Okay. No more question. Okay, Siwa.
Okay. So I think everybody will be agree. This is a very excellent talk by Dr. sharing by Dr. Anis and Dr. Amelia. Yeah, thank you, Dr. Anis and Dr. Amelia as well.
Thank you so much for the time.
Thank you. Thank you everyone also for joining.
Okay.
Okay, bye.
Sunny.
Thanks, Anis.
Thanks.
Bye. Thank you.
Thank you, Octopus.
Who's Octopus?
Because she go everywhere.